Namaskar. This is Dr. Monali Radkar from USA. Good morning from USA and good evening in India for all the people joining from India and USA. We have a very interesting and important topic today, early detection and prevention of cancers. We did do part one a few months ago, and this is part two covering colon, lung, and prostate cancer. And please respect the audience to our YouTube channel and Facebook. The previously on our YouTube channel and also on Facebook. So we do take these different topics in our monthly webinars. So please stay tuned, and also we will keep you updated on different topics. We have done depression, and so our goal is to make aware or increase the awareness of important social topics in the society of different segment, especially rural part of India and low socioeconomic segment of developing countries. So I would like to introduce my friend and colleague, Dr. Jagathi Challagalla. She has experience of over 25 years and hematology, oncology, board certified. She graduated from Montefiore Medical Center, the University Hospital of Albert Einstein College of Medicine. She's also a medical director and lab director of Texas Oncology, one of the largest oncology oncological services providing facility in United States of America. So we will be covering lung, prostate, and colon. Please see our recorded sessions from our website for previous webinar. Ask Dr. Jagathi Challagalla to start the webinar. Thank you.
Good morning. Slides. Good morning for folks in USA and good evening for folks in India. There will be time to ask questions at the end of the talk. So let's start with colorectal cancer. One caveat or one thing that has become a big issue both in USA and India is a rise in colorectal cancer, and the patients have become much younger. I'm treating patients in their 20s and 30s with advanced colorectal cancer. So we'll go through certain risk factors and you'll understand why patients have become much younger with colorectal cancer. I have several patients even in India without family history who are in their early 30s with advanced colon cancer. So it's a worldwide problem, not just in the USA. So the risk factors that we can change, and let's look at risk factors that we cannot change. So let's go with the risk factors that we can change. So these are the ones that are something that we can do something about. Example, being overweight is a risk factor for several cancers. You know, uterine cancer is another one, breast cancer. So even with colorectal cancer, being overweight or obese is a significant issue. And not being physically active. So if you can exercise, brisk walking for 30 minutes, 3 times a week, you will decrease your chances of many cancers, certain types of diets. And I really want to stress upon this because right now with the younger patients having colorectal cancer. The oncologic societies are thinking that it's probably diet and environmentally induced cancer. So a diet that is high in red meats, beef, pork, lamb, goat meat in India, liver, and processed meats like hot dogs and luncheon meats. So what is this? So we see the diet change in a lot of Indians too. You know, we see that the marketing of processed meats have become so good that youngsters are wanting to eat hot dogs and, pepperoni and, sausages, etc., which are highly processed meats. So when they're processed, it causes certain changes in the cell level, and that has been shown to increase your risk for colorectal cancer. Cooking meats at very high temperatures, frying, broiling, grilling, creates chemicals like we see that in this part of the world, barbecue is a big thing, and smoking meats, they put in a smoker for a day or so. It does increase your risk for gastrointestinal cancers. And say in India, you're frying puris, and you use the same oil to fry something else, there is a risk because chemicals are released into the oil and inside into the food. And that sort of a diet is going to put you at a higher risk for colorectal CM. So low level of vitamin D increases your risk for colon cancer, pancreatic cancer, and many other cancers are coming into play now. So a lot of us are vitamin D deficient, and you might think, hey, I'm out in the sun playing tennis, or, I'm out in the sun for, half a day and my vitamin D will be good. No, you have to get your vitamin D 25 hydroxy vitamin D checked, and you would like to keep it in the 50 level. Because not only does vitamin D deficiency increase the risk of several cancers, but also thins down your bones and can cause thinning of the bones, osteopenia and osteoporosis, and increase your risk for fracture. So checking a vitamin D level should be every primary care doctor's responsibility. And also you should ask your doctor to check for your vitamin D level. It's important for your general health. So eating a healthy diet is important. Plenty of fruits, vegetables, whole grains, and avoiding red meat, processed meats, and sugary drinks like sodas, will decrease your risk for certain cancers and also keep you in good general health. Smoking, again, a biggie. Smoking increases your risk for several cancers. We all think it's only lung, but it's also head and neck. We've covered it in the previous meeting, and alcohol use. Alcohol use is throughout the GI malignancies. You can say that alcohol use has a role to play, whether it is colon cancer, esophageal cancer, head and neck cancer, liver cancers. Alcohol use and pancreatic cancer. Alcohol use is a risk factor. So factors or risk factors that we cannot change. This is not in our hands to change. We all will age. As we age, the risk for cancers does increase. But as I said previously, with colorectal cancer, they're getting younger and younger. A personal history of colorectal polyps, will increase your risk for colorectal cancer. If you have been cured of colorectal cancer previously, that also puts you at risk for a second bout with colorectal cancer. Personal history of inflammatory bowel disease. So what is this? This is ulcerative colitis, Crohn's disease, which are inflammatory bowel, come under inflammatory bowel disease. These patients have a significantly higher risk for colon cancer and rectal cancer. Family history. So we're going to go into that, delve into that a little bit more later on. Family history of colorectal cancer and adenomatous polyps. So if mother, father, brother, sister had a lot of polyps or colon cancer, your risk becomes 3 times that of the general population. So inherited syndromes, we'll talk about that a little bit more, and racial and ethnic background. American Indians and Alaska Native people have higher rates of colorectal cancer, and they do think that it's probably their diet and environmental changes. Type 2 diabetes, did someone have a question? Type 2 diabetes also increases your risk for colon cancer. Type 2 diabetics are generally obese. Therefore, that is another risk factor for this malignancy. So coming into the family history and inherited syndromes. So Lynch syndrome is a big one, and the patients are much younger. It's a most common hereditary colorectal cancer syndrome. The lifetime risk of colorectal cancer in patients with this condition could be almost 50%. But in that gene, it also depends on which part of the gene is affected. So your risk for developing colon cancer, endometrial cancer is uterine cancer, and other cancers in Lynch syndrome are ovarian, stomach, small intestine, pancreas, kidney, prostate, breast, and ureters, which are the tubes that connect the kidney to the bladder, and bile duct. And this is something that is really not being paid attention to outside the US. I have several patients in India who have the Lynch syndrome, and they say, oh, I've been diagnosed with prostate cancer, and they're like 60 years old, which is considered young with the prostate cancer. And I say, hey, did you get your somatic and germline testing done? No. My mother had uterine cancer. You have to have your family history, and you have to tell your doctor, and you have to be proactive and say, do I have an inherited syndrome? Because you can see the number of malignancies that are associated with this syndrome, and it is a real thing. So you have to be proactive and ask your doctor to get it tested. Familial adenomatous polyposis. This is when you get a colonoscopy done, you have so many polyps. It will be like a bed of polyps in your colon. And in these patients, you need your colonoscopy starting at age 10 to 12 years. So that's a pretty young age, and cancer usually develops in one or more polyps as early as age 20. And by age 40, almost all people will have colon cancer. So this is a big risk factor. So one of the things is, suppose someone has a colonoscopy and the doctor says, oh, you have a lot of polyps. You have to ask your doctor to get that tested, and the family members also to be tested. So the American Cancer Society recommends that people at average risk, meaning not with family history or any of the syndromes that we just talked about, to start regular screening at age 45. It used to be age 50. Between age 50 to 55, you have to have your first colonoscopy, but they moved it to age 45, and very soon they're going to move it to 40 and probably even younger, because as I said, they're younger and younger patients with colorectal cancer now, the sensitive test that looks for signs of cancer in a person's stool is called a Cologuard test. But I would strongly urge that your first screening test should be a colonoscopy, and do not rely on a Cologuard, because it can be false positive or falsely negative. Both are bad, So if it's false positive, you'll need a colonoscopy again, either which way. And if it's falsely negative, you can miss cancer. So the colonoscopy or the visual exam is very important, okay? People who are in good health with a life expectancy of more than 10 years should continue to have regular colorectal cancer screening through the age of 75. For patients who are 76 through 85, then it's a shared decision making. You have to talk to your doctor. How healthy are you? Like example, If you're 78 years old and in a wheelchair with bad heart and bad lungs, that person is not going to tolerate a colonoscopy, and probably their life expectancy is not going to be over the age of 85. And you have to see, okay, so what did this person's colonoscopy show previously? Suppose they had multiple polyps, then they need to be tested. People over the age of 85 should no longer get colorectal cancer screening per American Cancer Society. However, there's a little caveat to it. So if you're a very healthy 85, or if you're over the age of 85 and are iron deficient, if you have iron deficiency anemia, or if you're having any blood in your stool or black stools, you have to get a GI workup done, gastrointestinal workup done with colonoscopy and upper endoscopy. So all this that I'm saying is not written in stone, because each patient is different and the general health of the person is important, and their family history is important, and their symptoms are important. A postmenopausal female with iron deficiency or a male with iron deficiency has to have a complete gastrointestinal workup, colonoscopy and upper endoscopy, because we might miss a cancer, a bleeding ulcer, or any other non-cancerous lesions, which are important too, So for screening, people are considered to be average risk if they do not have a personal history of colon cancer or certain types of polyps, that is the adenomatous polyps, a family history of colon cancer, colorectal cancer, a personal history of inflammatory bowel disease, ulcerative colitis or Crohn's disease, or a confirmed or suspected hereditary colorectal cancer syndromes that we talked about, and a personal history of getting radiation to the abdomen or pelvis. So who are these folks? So folks who got treated for cancer of the cervix, cancer of the uterus, they're cured now, or had a rectal cancer and got radiated to the pelvic area previously, they're considered high risk for colorectal cancer. So stool-based test is fecal occult blood testing, and now the Cologuard test, they're highly sensitive. You can get it every year if you are not a candidate for colonoscopy, or you're too sick to have the colonoscopy prep. Multi-targeted stool DNA test every 3 years is also available here, but I do not know if that is widely used in India, because so far I have not seen a patient who has had this done in India. So visual exam of the colon and rectum is extremely important if any of the above tests are positive, or if you have symptoms like blood in the stool, abdominal pain, black stools, etc. So if it is done for screening, colonoscopy every 10 years, beginning at age 45, as I said again, that is probably going to be changing. And this is if you do not have polyps in the colon, then you go for colonoscopy every 10 years. Now, CT colonography, virtual colonoscopy was pushed quite a bit, but it's not adequate. If for some reason you cannot have a colonoscopy, either because of prep issues or you have a redundant colon and they're unable to clean it out to visually examine, then it's every 5 years CT colonoscopy. Flexed sigmoidoscopy every 5 years. Again, this is inadequate exam, but for certain patients where you cannot do a colonoscopy, you do just a sigmoidoscopy and then combine it with a CT colonography. For people at high risk or increased risk, a strong family history of colon cancer or certain types of polyps, that's the adenomatous polyps that we talked about, personal history of colorectal cancer, certain types of polyps, personal history of IBD, known family history of hereditary cancer syndromes that we talked about, and personal history of radiation. This is something we already went through. So people at increased risk for colon cancer. So when I say family history, it should not be, oh, my great-grandmother had colon cancer. No, it should be one or more family members who have had colon or rectal cancer. so immediate family, mother, father, brothers, sisters, and then you have to go to the grandparents. So that is how immediate family first, and then your grandparents. People who have had certain types of polyps removed during a colonoscopy. These are what your gastroenterologist is going to tell. Endomatous polyps, flat polyps, are generally at a higher risk, and you need to get a colonoscopy after 3 years. People who have had colon or rectal cancer and are cured from it, most of these people need to start having colonoscopy. It's usually 1 year after surgery to remove the cancer. And then if you don't have any polyps at that time, then it's 3 years, 5 years. But otherwise, if you had multiple polyps, it has to be again, not only the 1 year after cancer, but a year after. And then depending on the number of polyps, year 1, 3, 5. People who have had radiation to the pelvic area, most of these people will need to start colorectal screening. Colonoscopy is recommended. Stool blood testing is not adequate. Why? Because if you've had radiation to the pelvic area, if your rectum is in the field, you can have a proctitis, which is inflammation of the rectal area, and you can have some bleeding, and your stool-based testing will not be adequate at that time. So for these patients, you have to have colonoscopy at an earlier age, depending on how old they were when they got the radiation. Screening often begins 5 years after radiation was given, or at age 30, whichever comes last. I hope I'm clear about it, These people might also need to be screened more often than normal, not every 10 year, this thing. It should be at least every 3 to 5 years. So people with Crohn's disease and ulcerative colitis. Crohn's and ulcerative colitis is fairly common in our Indian population. So it should start at least 8 years after they're diagnosed with inflammatory bowel disease, and follow-up colonoscopies, depending on how severe their Crohn's disease or ulcerative colitis is. It has to begin at least 8 years after they're diagnosed, and then it needs to be repeated every 1 to 3 years. These patients with Crohn's disease and ulcerative colitis are also at risk for other malignancies, GI cancers, such as gallbladder cancers and bile duct cancers. So take home message, I kind of combined what we did last time, in an average woman, breast screening begin age 40. Earlier, if you have a family history of breast cancer, we went through that in the last talk. Cervical cancer, HPV, human papilloma virus, age 21. HPV vaccine, recipient 21 years to 29 years and every 3 years. The HPV vaccine is very important and unfortunately not widely used in India, or even in USA. They forget to get their children vaccinated for human papilloma virus. Not only for cervical cancer, but it has become a big problem with head and neck cancers. And there are much younger patients with head and neck cancer with more advanced disease with HPV. 30 years or above, every 3 years pap smear, or every 5 years with pap smear and human papilloma virus testing. High risk HPV positive patients, every year they need a pelvic exam. Now coming to colon cancer, average risk 50 years colonoscopy. Nowadays it's age 45 and it's going to become younger, but the guidelines are changing. And then every 10 years, if no polyps are seen and no abnormalities are seen. Prostate, age 50, needs a prostate exam, average risk, early PSA, and a digital rectal exam. Now, this is for an average patient, that is no family history and none of the hereditary syndromes that we talked about. Shall we go to lung cancer, or any questions? Let's go to lung cancers. So lung cancer, very, very common cancer, one of the most common cancers that we see. Smoking, 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 whether you're smoking or whether your family members are smoking inside the house, inside the car, it increases the risk for everybody who's exposed to smoking. Smoking is by far the leading risk factor for lung cancer. 80% of lung cancer deaths are thought to be due to smoking. And this number is even higher for small cell lung cancer. So lung cancer comes into two, you can divide all the types of lung cancer into two main types. Non-small cell lung cancer, which is about 80% of lung cancer is non-small cell lung cancer. 20% is small cell lung cancer. Small cell lung cancer is always associated with smoking. It's very rare for someone who has never smoked to have a small cell lung cancer. Cigar smoking, pipe smoking are almost as likely to cause lung cancer as cigarette smoking. Youngsters nowadays are doing vaping, and vaping also increases your risk for lung cancer. Secondhand smoke, if you don't smoke, breathing in the smoke of others, can increase your risk of developing lung cancer. Secondhand smoke is the third most common cause of lung cancer in the US and even in India. Exposure to radon, nowadays we are more careful about that. But if in the past you've been exposed to radon, we see that in a lot of patients who have served in the army, etc., who've been exposed to radon, they develop lung cancer later on in life. People who work with asbestos, mines, mills, textile plants, where insulation has been used in shipyards. You see that a lot, in Andhra, there's a lot of lung cancer in the Visakhapatnam population because of the shipyards there. Radioactive ores such as uranium, inhaled chemicals, arsenic, beryllium, cadmium, silica, nickel compounds, chromium, coal, people who work in the coal mines, mustard gas and all during wartime. Or in the nuclear fields, you're going to see increased lung cancer. Diesel exhaust, this has become a big problem all over the world because of pollution. If you go to Delhi nowadays, you can't see the sky because there's so much pollution there. Taking certain dietary supplements. In fact, 2 large studies found that people who smoked and took beta-carotene supplements actually had an increased risk of lung cancer. Arsenic in drinking water, Southeast Asia and South America has very high levels of arsenic in their drinking water, and this increases the risk of lung cancer and also certain blood cancers. Prior radiation to the lungs. Previously, tuberculosis in India was treated with radiation. So in that scar where the radiation was given, you can develop scar carcinomas, which is adenocarcinoma of the lung. Air pollution. This is a big problem in America and everywhere else. 1 to 2% of all deaths from lung cancer is due to outdoor air pollution. You might think of that as a small number, but with the billion population in India and with the traffic situation and pollution situation, which has become a big problem, this is a real number, meaning this is a real risk factor. Personal or family history of lung cancer. If you've had lung cancer, you have a higher risk of developing another lung cancer. If you've been cured, and you can get it even 10 years out. After that, you can develop a new primary. Brothers, sisters, and children of people who have had lung cancer may be at a slightly higher risk of lung cancer themselves, especially if the relative was diagnosed at a younger age. Right now, I'm treating 2 brothers. One is 33 years old, and the other is a 40-year-old gentleman, both of them with lung cancer. Factors with certain uncertain, we haven't have the proof yet, is smoking marijuana, e-cigarettes, and talc powder. Talc is a mineral that is in its natural form and may contain asbestos. So mesothelioma, which is cancer of the lining of the lung, is also associated with asbestos exposure. Hookah use, increased risk of lung cancer. So the American Cancer Society and the US Preventive Services Task Force and the American Association of Family Practice, American College of Chest Physicians give these recommendations. Yearly lung cancer screening with low dose CT scans. So low dose CT means you're not giving them that contrast to increase radiation risk. So that is not the usual CAT scan that we do for, say, somebody with cancer. This is a different kind of CAT scan where the radiation is not a problem. So low dose CT scans for people who are 50 to 80 years old and in fairly good health and are smokers or have quit in the past 15 years and have at least a 20-pack year smoking history. So what is 20-pack year smoking history? 1 pack a day for 20 years or 2 pack a day for 10 years, or 4 packs a day for 5 years is still considered a 20-pack year smoking history. So this is something that's not being currently done in India. This is something that I've pushed a lot in India whenever I go, because we have a lot of smokers still, and a lot of them fall in this category. So this is something you have to do because you can diagnose it at a very early stage. It could be just a small spot in the lung and then it is curable. So this is something I would really encourage you all to speak to your physicians, And the good thing about in India is you really don't need a physician's order to get a scan. Anybody can go and get a low-dose CT scan, at a radiology facility. So screening for lung cancer in the above population is done yearly. Once a year, you need a low-dose CT scan. So I hope it's not too much material. Let's go to prostate cancer. Prostate cancer is very, very common. Yesterday I got a call from California, an Indian gentleman who's 70 years old with metastatic prostate cancer in the bones, lymph nodes, etc., and didn't have PSA done for the last 2 years because of COVID. They were afraid to go to the doctor's office. So age, prostate cancer is rare in men younger than 40, but the chance of having prostate cancer rises rapidly after age 50. About 6 in 10 cases of prostate cancer are found in men older than 65, So it is very, very common. And this is the cancer that a lot of men do not go and get tested for until they start having symptoms like back pain, or a fracture, and then they go and get tested. By then it has already metastasized. Prostate cancer develops more in the African American men and in the Caribbean men, and less often in Asian American men. But that is on the rise now. So in India, there's a lot of prostate cancer and it is on the rise. Prostate cancer is most common in America and Northwestern Europe, Australia, Caribbean, less common in Asia, Africa, Central America, and South America. But all these countries are seeing a rise because we are living longer and the diagnosis has become also in the younger population if they have any hereditary syndromes that we're going to talk about. Family history. Most prostate cancer occur in men without a family history of it. So you cannot think, oh, there's no prostate cancer in the family. Like, yes, good evening, gentlemen. No prostate cancer family history, but he has it. So this is one thing that you have to think of getting it checked regularly. As I said, you have to begin at age 50. Inherited mutations. BRCA1 and BRCA2 genes. We covered this in the breast cancer talk that I had given previously. This is linked to an increased risk of breast and ovarian cancer in some families and increased risk of prostate cancer in men, especially BRCA2 gene. I'm going to mention this specific point now. they have to be tested. And unfortunately, this is not being done. The BRCA gene mutation has to be tested if you have prostate cancer, not only on the tissue, but also in the blood. Let me explain why. So if you have prostate cancer, the gene sequence panel has to be done on the tissue because there are certain treatment options that you can have which really work, so you might not have a family history, but the cancer cells might mutate and show these genes in the tissue itself. So if you don't get tested for that on the tissue, thinking I don't have a family history of BRCA1 or BRCA2, you're going to miss certain very good treatment options. So why did I say you have to get it tested in the blood also? The blood is the germline testing, meaning that is the test that you have to see that is probably going to put not only you, but also your family members at risk for having the gene. So if you test positive in the blood, that is called germline mutation. You or your family members have to be tested also, whether they have cancer or not, because we have to follow certain guidelines, which will be a separate talk. It's too long for today. Certain guidelines we will follow if you have any of these mutations. Men with Lynch syndrome, which we talked about, the hereditary non-polyposis colorectal cancer, are also at risk for prostate cancer besides colorectal cancer and many other cancers that we talked about in the slide previously. Diet. This is something which we feel that folks who eat only dairy products or a much higher level of dairy products have a slightly higher chance. Some studies have suggested that men who consume a lot of calcium, either through dairy or food supplements, may have a higher risk of developing prostate cancer. Obesity does not seem to have a role in increasing prostate cancer. Used to be thought, but no longer a risk. And firefighters, because they're exposed to certain chemicals, have a higher risk for prostate cancer. Most men without prostate cancer can have PSA levels under 4 nanograms per ml in the blood. So you can have an enlarged prostate, and it's called benign prostatic hypertrophy. And you can have a slightly elevated PSA. So these patients, though they have elevated PSA, needs to be followed up on a regular basis because they can develop prostate cancer as time goes along. Men with a PSA level between 4 and 10, this is called the borderline range, have a 1 in 4 chance of having prostate cancer. This is what I was talking about. You can have benign prostatic hypertrophy, and if the PSA is trending upwards, you need a biopsy because you have a 1 in 4 chance of having prostate cancer. If the PSA is more than 10, the chances of having prostate cancer is over 50%. Now, I know I just said that, but there is a rarer variety of prostate cancer, which is a poorly differentiated prostate cancer or very aggressive prostate cancer, where you can actually have a lower PSA, So that is the reason why if your urologist or whoever is checking your PSA levels cannot rely entirely on just the PSA and has to do a digital rectal exam also. So factors that might raise the PSA and is not due to prostate cancer is an enlarged prostate, that is the benign prostatic hypertrophy or BPH, older age, inflammation of the prostate, ejaculation, riding a bicycle and then getting a PSA done right away, certain urologic procedures. Suppose you just had a cystoscopy, which is examination of the bladder, then, or you had a Foley catheter placed because you're not able to urinate, then your PSA is going to go up. Certain medications, testosterone replacement has become a big issue in the United States. Many young men and older men have a low testosterone level and they feel tired and fatigued. So their doctors give them testosterone replacement, which increases your PSA levels and also increases your risk for prostate cancer. If screening results are not normal, you have to have a digital rectal exam. That was what I was mentioning in the previous slide. Waiting a while and having a second PSA test is appropriate. Getting another type of test to get a better idea if you might have cancer, and therefore should get a prostate biopsy. That is when your PSA is rising, or when you do a digital rectal exam and you see any nodularity in the prostate, you have to have a prostate biopsy. Getting a prostate biopsy to find out if you have cancer, if your digital rectal exam is abnormal, you have to have a prostate biopsy. It's important to discuss your options, your age and overall health. Example, if you are in very poor health and you are, say, 85 plus, and you have an indolent, meaning slow growing prostate cancer, bad heart, bad lungs, it's unlikely that the prostate cancer is going to kill you. It's probably your other medical problems that are going to kill you. The likelihood that you have prostate cancer based on the test done so far, your PSA level, digital rectal exam, etc., is something that's going to play in a role when you talk to your doctor about what you do next, and your own comfort level with waiting or getting further tests. Example, if you're 90 plus years old and wheelchair bound, I'm not so sure that you're going to go and get a prostate biopsy, etc., if you're not in a good shape. But there are a lot of 90-year-olds who go and play golf and they're in great shape. In them, I would strongly recommend getting testing done, because we have much better drugs now, for treatment of prostate cancer that we didn't have before. So take-home message, again, same slide. Prostate, age 50 for men at average risk, early PSA and a digital rectal exam. So, we went through the breast screening and cervical and colorectal screening previously. So this is the time, if anyone has any questions, I'll be glad to answer. This is the last slide.
Yeah, if you have any questions, thank you so much. If you have any questions, please let us know. हिंदी में भी आप पूछ सकते हैं, मराठी में भी आपको अगर प्रश्न होगा तो पूछ सकते हैं, एंड मैं ट्रांसलेट कर लूंगी उनके लिए. पर लेकिन बहुत इम्पोर्टेंट इंफॉर्मेशन, बहुत महत्वपूर्ण information we have had it regarding these important lung, prostate, and colon cancer, GI students and the children.
Yes, it's in the chat box, and I'll read it. How has the recent pandemic of COVID-19 affected or influenced the traits of cancers? So it's a great question. So let's start with screening. A lot of patients did not get their mammograms, did not get their colonoscopies, EGDs, did not see their physicians during the COVID pandemic. So unfortunately, we're seeing a much later stage cancers, this year and end of last year, we're seeing patients come in with much late stage cancers, because they haven't been screened for the last two and a half years.
How about young people, their habits and nutrition?
Yes. I'm treating a 22-year-old, and in their late 20s and 30s, I have, I think, just off the top of my head, I can say I probably have about 10 to 11 patients who are in their 20s and 30s and early 40s, probably a little bit more, I should say, with colorectal cancer and gastric cancer. Gastric cancer is on the rise also in the Hispanic population and Asian population. And cholangiocarcinoma is on the rise in the Asian population. It's because of the diet. We're still not able to figure out whether it is diet alone or there's something else in the environmental thing. Diet, of course, has been proven. As I said, processed meats, all of us have gotten very busy in our lives, and we just slap on some processed meat and eat a sandwich, or it's become the Western lifestyle has picked up in Eastern world, meaning When I was growing up, to get to eat sausage or hot dogs or pepperoni was not available easily. But now, it's available everywhere in India, and the youngsters want to eat processed meats. They love their processed meat, this thing. So that is why even in India and in the US, patients are getting younger and younger and more advanced disease. Why is that? Because if a 20-year-old or a 30-year-old says, hey, I'm having abdominal pain or blood in the stool, they're thinking it's hemorrhoids, or if they're developing iron deficiency anemia, they're thinking it is probably they have an ulcer or this thing. So they're diagnosed much later. They're not sent to the gastroenterologist, or the GI workup is not happening. So they're diagnosed much later. And unfortunately, all the youngsters I have are, with liver metastasis or lung metastasis, This week I saw a 31-year-old young female who's a volleyball coach, unfortunately, with liver metastasis. She has the Lynch syndrome, and none of her family members were ever tested. And, her mother had uterine cancer at a young age, but never tested. And when I tested her somatic genes for gene sequence panel to guide what therapy I give, which we give immune therapy and not chemotherapy. So big difference. If you don't test, you're going to get the wrong treatment. So she will be on immune therapy, and her prognosis is definitely better because she has Lynch syndrome, and we can use immune therapy, and we can actually cure with stage 4 cancer a large proportion of people.
Yeah, very important information. Amit, can you hear me? ऐकू येतंय का तुला?
हो मॅम.
हाँ, तर आई विल रिक्वेस्ट, मैं अमित को रिक्वेस्ट करूंगी कि वो हमारा जो लाइब्रेरी का जो प्रोडक्ट ये जो प्रोजेक्ट चल रहा है तो वो उसके बारे में अनाउंस करे.
I think out of the entire talk, I think screening is what you all have to really take home because unfortunately, screening is something that is ignored. You feel, I feel healthy, I don't need it. Even mammograms, people are not getting yearly. You should, the basic screening has to be done.
Amit?
हाँ, यस मैम. आप सभी को नमस्कार. आप सभी को मेरा नमस्कार. हेलो जगती मैम, आपसे मिलकर बहुत अच्छा लगा. आपका सेशन बहुत यूजफुल रहा और आपके सेशन से एक अवेयरनेस, बहुत अच्छा अवेयरनेस हुआ है मैम हमारी इंडिया में भी. तो मैम मैं अपने सेतु का मैं एक छोटा सा हिस्सा हूँ और मैं अपने ब्लॉक में सेतु का एक वॉलंटियर के तौर पे काम कर रहा हूँ. महाराष्ट्र के अंदर यवतमाल एक जिला आता है और यवतमाल जिले के अंदर एक वडगांव रोड करके एक ब्लॉक है. वहां पे जिला परिषद यानी जेडपी की अंडर आने वाली स्कूल है जहाँ पे 1ली से लेके 8वीं तक के बच्चे पढ़ते हैं. अब इंग्लिश मीडियम का जो क्रेज है वो हर इंसान तक पहुंच गया है. हर किसी को लगता है कि हमारा बच्चा इंग्लिश मीडियम में ही पढ़े, लेकिन उस जेडपी के स्कूल में उस इंग्लिश मीडियम के स्कूल का मेंटेनेंस, फीस जो नहीं भर सकते वो बच्चे वहां पे है और उनके माता पिताजी जो पेरेंट्स है वो टोटली निरक्षर है. उनमें एजुकेशन का कोई मतलब आता नहीं. तो ऐसे स्टूडेंट्स के लिए हमने वहां पे एक लाइब्रेरी, एक प्रोजेक्ट हाथ में लिया है. तो हम वहां की एक स्कूल हमने अरेंज की है. उसी स्कूल में परमिशन लेकर हमने उस एक क्लासरूम को, जो क्लासरूम बंद था, वहां पे हमने लाइब्रेरी शुरू की है. और उसके लिए हम अपील कर रहे हैं कि हमें किताबें मिले. हम सभी मान्यवरों से, संवेदनशील लोगों से यही दरख्वास्त कर रहे हैं कि हमें कुछ किताबें मिल जाए जिससे बच्चों का जो कॉम्पिटिटिव एग्जाम दे रहे हैं उन स्टूडेंट्स का और हर किसी का फायदा हो. ये हमारा प्रोजेक्ट यवतमाल, अमरावती जिले के मेळघाट जो कि ट्राइबल एरिया माना जाता है वहां पे, और ठाणे जो एक बड़ा जिला है वहां पे भी हम ये प्रोजेक्ट 3 जगह कर रहे हैं. तो इन तीनों ही जगह हमारा एक संकल्प है कि हम वहाँ पे किताबें पहुंचाएं और वहाँ पे हम वॉलेंटियर सेवा देकर वहाँ पे लाइब्रेरी प्रोजेक्ट शुरू करें। तो मैं सेतु की ओर से और अपने यवतमाल के सभी टीम की ओर से अपील करूंगा कि आप सभी हमें डोनेट करें किताबें, और उस किताबों से हम एक अच्छा समाज घड़ाने के लिए प्रयास करेंगे। थैंक यू एवरीवन।
डेफिनेटली, जरूर। और किताबें में इवन हेल्थ किताबें एड्रेसिंग हेल्थ इज आल्सो इम्पोर्टेंट, and it should start at a young age. So जरूर।
Thank you, Ami. Excellent. So any questions है आपको, और कोई questions है? Thank you.
So there's a question on the chat box. Can a detection of one cancer play a role in having another cancer of different type?
Excellent. So any questions है आपको, और कोई questions है? तो
There's one in the chat box. So yes, so detection of one cancer play a role in having another cancer of different type. Absolutely. So if your example, if you are a smoker, let's say, and you have head and neck cancer, then you are also likely to have a lung cancer. And if it's a female, then cancer of the cervix, any midline cancers, easy thing to remember is smoking increases the risk of all midline cancers, beginning from lip to oral cavity, head and neck, larynx, lung, then esophagus, pancreas, cervix, so to remember easily, just think midline cancers, so yeah.
Very good. We will end. Thank you so much. अगर कोई questions नहीं तो we will end. Very good session and very good information. Important information जो कि इंडिया के पेशेंट को भी महत्वपूर्ण है, कि कैसे अर्ली डिटेक्शन करे, प्रिवेंशन करे, एंड जो टेस्टिंग है फैमिली में है तो क्या क्या टेस्टिंग करनी चाहिए, जेनेटिक टेस्टिंग भी हो सकती है। तो हम लोग जेनेटिक का भी एक आई थिंक सेशन ले सकते हैं नेक्स्ट टाइम। तो एक्सेलेंट सेशन एंड वेरी इंफॉर्मेटिव इंफॉर्मेटिव सेशन हो गया है। सो स्टे ट्यून फॉर द रिकॉर्डिंग अवेलेबल, and we will upload it on our SETU International Foundation YouTube channel. Thank you very much.
Thank you all for attending. Any questions later, please do not hesitate to reach me.